Welcome to Cracking Cancer, where we tackle the tough questions about cancer with real patients and world experts. Our mission is to empower the cancer community through education, bring transparency to the oncology system, and drive funding for critical cancer research. Whether you're facing a diagnosis, supporting a loved one, or simply here to learn, we're here to bring clarity, hope, and action to the fight against cancer. Hey everyone, welcome to Cracking Cancer. I am your host, Dr. Kyle Concannon, and today we'll be talking about male fertility and how that can be affected during cancer treatment. With me to talk about that are two legends in the colorectal cancer community. We have Dr. Cathy Ang and JJ Singleton here. And Cathy and JJ, maybe you can tell us a little bit about yourself.
I guess I'll go ahead and start. I'm a medical oncologist at Vanderbilt Ingram Cancer Center, and I conduct clinical research in colorectal cancer. And I have a special interest in early onset GI malignancies, but especially colorectal carcinoma. This is a patient population that I've been seeing regularly in my clinic since starting my practice. And I really, you're so moved by the patients that you meet. It's really hard not to try to connect with them and hear their stories. And I think this was a wonderful opportunity that I got to meet JJ through various venues, including social media, and really hear his story.
And I'm JJ Singleton. I'm a 37-year-old colorectal cancer patient survivor. This September will be 10 years since I was diagnosed. I live in near Asheville, North Carolina, and I'm just honored to be here to be able to share a little bit of my experience that I've gained and everything that I've been through over the last, almost 10 years now.
Well, thank you both so much for joining us here and for your expertise in this area, and particularly around the topic of male fertility, because I think we as a community have some work to do. We were talking about this before we launched on, that there's a lot of missed opportunities here, and there's a lot that people don't know. There's stigma around it. So I'm really excited to, get into it and dive headfirst into tackling this. Cathy, maybe we can start with you. Maybe just hear, you told us a little bit about your clinical background, but around this topic of male fertility, why are you drawn to tackling this problem?
As I mentioned, I tend to see a lot of early onset patients in my clinic, and it's a very important matter to discuss with our young patients because obviously family planning is at least a big discussion in my clinic. It should be really for all physicians that see the early onset patients, right? And so we just want to make sure that people are informed, people think about it, and people engage their patients in further discussion. Sometimes on the first meeting, it doesn't necessarily go over well regarding focusing on fertility planning, just because there's a lot of information that's provided to patients in the first visit, and it's a bit overwhelming. But I think it's very important to keep in mind to make sure that is discussed before treatment is initiated.
And JJ, you've had a complicated story and background, particularly around male fertility. Can you share your history and how fertility became part of your cancer journey?
As I said, I was diagnosed when I was 27. So right before I turned 28, I was single. I didn't really have any, interest in fertility or anything at that point because I was just trying to live my life. And I live in a small area, outside Asheville, North Carolina. So there's no major cancer centers around, and nobody told me anything about what I should do about fertility or if there's any options or what I should think about. And I go into my first meeting with my oncologist with my mom, and one of the worst experiences I ever had is they thought that was my wife, and they started talking to me about all of that. And I was just like, no, we're done with this conversation right here. Can't do this. But
that'll do it.
Yeah. But then even after that, I didn't hear anything about it. And everything in my world that they told me at that time was like, 6 months chemo, you're going to be fine. You've already had the tumor removed. You'll be 28. So I was like, well, should I ever even worry about anything about sexual health or fertility? Well, obviously my case kind of got complicated after that. And then, by the time I was rushed into treatment again, it was too late for me to do anything. So just a lot of complications and a lot of knowledge and opportunities that weren't provided to me.
So then you didn't really have a lot of initial discussion around fertility when you were starting your care, planning what your care was going to be. When did this topic eventually come up?
It didn't really come up until I went down to Duke when they were, my cancer came back. And at that point, it still didn't come up until I started doing the stuff into the clinical trials after all the other treatments had failed me. And that's when they were like, we don't know if you will ever be able to, have kids, or we don't know what's going to go on in the future, because now you're into this clinical trial world where we don't exactly know how the drug's going to impact the fertility or just anything that's going on in that realm. So that was the first time I'd ever got told about it, but also the first time I ever got told that there might be a lot of complications moving forward.
Yeah, and was this like over a year after starting your initial therapy? It sounded like it was later in the game.
No, I started chemo November of 2015, and this was June of 2016. So it was, within a year. Like, everything happened to me really quickly there for that first, year and a half.
What were the emotions that you were feeling when you were told that your fertility was compromised?
Honestly, at that time, I didn't think I was going to live past the age of 30, because I was so used to treatments failing. And like, the clinical trial was my Hail Mary. There was no other options back in 2016 at that time that I hadn't already tried through. So honestly, it didn't even go into my mind at that time, because I was, am I even going to be alive to even, be in love with somebody, or to have the options to, reproduce or anything. And it didn't really impact me until later on, once the trial started working, and once I was like, well, maybe I am going to not recover, because I'm still on active treatment, but be able to have a life longer than a couple months or a couple years. And that's when it really started impacting like my mental health.
In what way?
Just that I was robbed of something that I think innately all humans, that to a point, people make decisions on if they want to, have kids or not, but to not even be able to make that decision, to have that decision kind of took away from me because I chose a treatment that, extended my life, just felt like I was robbed of something.
Well, and I imagine something, being told after the fact rather than making the decision up front, that must feel different, yeah?
Yeah, very different. Just that I was so used to not having power, because I was, everything was, if this treatment's going to work. And at that time, I wasn't as knowledgeable about anything about colorectal cancer as I am now. So all the power I pretty much gave to my doctors, my oncologist, and then just to not have that option. But then also, as the more I got, into the world, the more I was like, I don't even have anybody to talk to about it, because, guys just don't talk about that. And especially people in my area and my region. And, you don't talk about the shortcomings, or if something, took away from you where you can't do something. It's just, you're supposed to deal with it. So it just kind of all landed on the shoulders, and I didn't know how to process it.
Yeah, I want to dig into that more, but Cathy, when you first hear this story, what are your initial impressions? What comes to mind?
I feel a lot of emotion for him, because obviously JJ has been with us now for many, many, many years, and hopefully many, many more to come. And I think that obviously you have this sense that he wants to become a father, and would be an amazing father, and wasn't given that opportunity to necessarily bank his own sperm in preparation for this moment. But then clearly there was a lot of heavy decision making based upon where his treatment was going at that time. And I think it's important to keep in mind what JJ stated is, his journey started earlier when there weren't a lot of novel therapies for colorectal cancer. And so he was very much dependent upon clinical trials. And so he's completely correct as well. We don't know a lot of the side effects for early phase clinical trial development. And obviously that's really where there's so many unknowns. So I think his story really should continue to really have an impact on everybody, I hope, that listens to this, not only patients but also healthcare providers, so that they will understand that we can negatively impact, a patient's future in regards to family planning if we don't discuss it early up front.
And what are the circumstances, Cathy, in which you would discuss male fertility, sperm banking, those kinds of topics?
Actually, for any patient that is considering any type of treatment, you shouldn't presume it was discussed in the surgeon's office. So in JJ's case, he had already gone to surgery before he went to see the medical oncologist, right? And so you hope it was discussed, with in your colleague's office, but it may not have been, right? So we have to presume that it's always a good idea to ask again. And when considering any type of chemotherapy, it should be discussed, regardless if it's colorectal cancer or any other cancer for that matter, because certain chemotherapy agents are going to have more impact than others. And then especially if there's any consideration of radiation therapy. So males obviously can potentially reverse some of the process, but you're also impacting potential sperm count and also the function of the sperm. And so, there's so many unknowns because every individual is going to be different. And so it's really important to have that discussion up front. And I think when you're telling this story right now, JJ, which, I was just thinking now you've been living with your cancer for so long and still on therapy, and you're in a relationship now, and how that must have impacted also a relationship, that discussion.
Yeah, well, I'm not in a relationship now or anything. No worries. That's still, maybe one day. But it's impacted me in that realm of my life too, because I'm always going to be completely honest. Like, I share my life, my stories, the good and bad, to the world. So of course that's going to be something I would tell somebody that I was talking to or getting in a relationship right up front, because it is a major aspect, especially as I'm 37, about to be 38 this year. That's something that's, in my mind, got to be talked about pretty quickly if I ever do get into a relationship, because that's a huge part of life for me and for anybody else. But over the last 10 years, it's definitely been, a driving point of like, well, do I even have a shot to be in a relationship if I can't provide that part of life?
Yeah, to what you're mentioning, JJ, I'm married now, but I was dating in my 30s. I was single in my 30s and on the dating market. And the pressure around having a family, I don't know if that's something that's impacted you, but when I've talked to people, other women who are in their 30s as well, I think the sense of a biologic clock is very real. Mm-hmm. And, for me, the pressure I was feeling was tough. Does the sensation that your fertility is compromised from the chemotherapy, does that affect you in the dating world?
I think so. I think it's a combination with me too, because I do have a genetic mutation that I'm very upfront about too. So when I combine those two, it might be more in my head than it is other people's, but I'm just like, that's like two strikes against me already, because I'm like, if I don't, if I can't have kids, that means that genetic mutation isn't going to get passed on to anybody. But if there was something where I was able to, that's a 50-50 chance there. But then especially with the fertility now into my life where it's at now over the so many years of treatment, and treatment isn't stopping for me unless, there maybe one day be a drug where I can space it out or have a breakthrough. But in my present time right now, I go every 3 weeks for treatment. So there's like no shot of anything changing. And it's definitely impacted me, at least in my personal aspect in dating life.
Well, and, I can attest that our psyche when you're on the dating market is pretty important, like how you think about yourself, how you feel you're perceived. There's all the approach anxiety, like guys get in their own head all the time. I'm sure it happens to women too, but those things that, like, any reason you can find in yourself to, be a reason why not to approach someone or have a reason why something wouldn't work. It's really easy for me, or it was easy for me, to find issues with my own self-value. Do you think that was playing, in your mind as well, that you have the Lynch mutation and then, this fertility, you're mentioning 2 strikes. Did that affect how you viewed your value?
Oh yeah, definitely. I've always had an issue with my like self-value of anybody that's really close to me will tell you I'm the hardest person ever on me. I see myself completely different than the world sees me around. I'm hard on myself, and it's something I'm working on, but definitely in this realm of like life and with relationships, and it's always been an issue, and it just kind of got elevated with the cancer and the fertility and the genetics.
And Cathy, we're mentioning how chemotherapy, radiation, these types of cancer-directed therapies can impact fertility. What are they doing? Like, what is actually happening that impacts fertility?
Well, I just want to be very clear. I'm not a urologist. And so I don't really specialize in this area. I would specifically in regards to sperm banking, but I would say that it's really critical to have that open discussion with your care team to make sure you are appropriately referred to a fertility specialist and a urologist that is interested in assisting the patient and getting as much information as soon as possible, and also keeping in mind it may not necessarily be covered by insurance. So that's another thing also to keep in mind as well.
Sure.
But as I mentioned earlier, we every patient's going to be different. So the impact with chemotherapy and radiation therapy can, obviously impact sperm production and also how functional the sperm is in fertilization. So those aspects can be questionable, and so it's really, really important to try to meet with a fertility specialist before any treatment is initiated.
Yeah, I think something you mentioned is how diverse the treatments are. Their specific effect on sperm count, sperm mobility, mutations. Cancer therapies are often causing mutations. That's how they work. How might that affect an offspring? And JJ, you had one type of chemo, but someone else has a different type. And how that might affect all these things is really variable. So, and even nowadays, we have therapies that don't work by attacking DNA, but that doesn't necessarily mean they're totally benign, and they don't do anything to fertility. A lot of this stuff isn't super well studied. So I think that's a big challenge for providers. And I think maybe that's a big reason why we're not doing as good a job. Cathy, what are your thoughts about why JJ wasn't referred for sperm banking? Like what goes through the provider's day, and how does this get dropped?
Yeah, I think what happens is, number one, often a healthcare provider is often very surprised to see such a young adult in their clinic, unless a genetic mutation is identified early on, right? Because the average age patient in the United States is always, roughly the mid to late 60s. So that currently the median age is 66 in the United States for colorectal cancer. So to see, a young individual such as JJ, 27 years old, that's in your clinic, it's surprising, right? And so there's a lot of urgency and the need to get things going as soon as possible for the patient. And I think that's where it's kind of lost in the discussion, where they're so focused on eradicating the tumor, treating the tumor, that they forget about the aftermath of what happens after the tumor's been removed, or what happens is once the treatment's been initiated. It's great that it's addressing the cancer and hopefully preventing any further tumor growth or spread. And in some cases, giving it in the adjuvant setting where the tumor's been removed. But it's easy, I think, when you're unfortunately in a very busy clinic, let's say, you may forget that there are some long-term side effects. And this young gentleman is going to hopefully live in a very, very long life, and he's going to have to plan for a future ahead, but the provider is not necessarily thinking that way during that quick first visit. So we have to kindly remind our healthcare providers how important that is. Just like checking your vital signs when you come into clinic, checking your blood work, there should be a box that says, have you had a discussion regarding fertility? In our consent forms now, it is clearly stated, have you discussed, fertility planning? There's a checkmark box for our patients, males and females. But, in 2017, that may not be the case.
That's great that your group has that. Yeah, it sounds like that there's probably an advancement, those kinds of things over the last 10 years.
Yes,
Um,
I would agree.
and we were mentioning the average person is this age, the average person has this survival outcome. And I think as providers, we think a lot in terms of how the middle of the pack does. We have this term median, which is what does the middle person do? So we have or our survival curves, and you'll see it go down over time, either overall survival or progression-free survival, and we tend to think about kind of average, but we forget sometimes, this is certainly guilty of me, that 10, 20, 30% of people don't fit the average. They do much better. Some people don't do as well, but we tend to think in terms of average. So I can imagine a world where JJ came into clinic, there's not a lot of options for Lynch syndrome associated tumors yet. JJ, you were on one of the first ones that worked crazy well. And they're thinking about what is the average experience. And you had an exceptionally good response once the immunotherapy kicked in. And as providers, I think we're not thinking that way. And this is one of the goals of this initiative is to understand different perspectives, how errors occur, and how we all work together to meet everyone's goals. I think the world where someone comes in with cancer and says, "I'll do whatever you want, doc," I think that world is getting harder to say you're going to get the best care every time because things are just so complicated. And certainly when we get into the world of how do you cope, the mental health element, which JJ, you've been so strong in advocating for, the medical oncology team, this is not our strong suit. This is something that we're, I think, learning in real time, hand in hand with patient advocacy organizations, really. And on that theme, JJ, you had mentioned later coping with the mental health repercussions of the compromised fertility from your chemotherapy. Can you speak a little bit to how that hit you, how you coped, what you needed to do?
Yeah, I think a lot of it because when I was on the clinical trial, I still was not in a good, or started the clinical trial, I wasn't in a good place mentally. It's well documented. I went through a lot of, deep depression from 2017, pretty much until 2020 when I finally found some help through therapy a little bit earlier on, but then finding some advocacy organizations like the Man's Group, and then just kind of broadened my space in there. But going back to this was just an added weight to it. It made me feel more isolated. It was another thing that was a barrier to all of my friends that I had for years since, childhood. I live in an area where I can walk down the street and my best friend who I was neighbors with in elementary school lives a mile from me. I see people every day that I went to school with, but it was just another barrier because they were all having kids. So now they were having their new friends were their kids' parents that they went to school with, as everything always is. And I didn't hold it against them, but it just made me feel more isolated, made me want to stay more in that room and not get out of the bed that day because I would get invited to their birthday party or their kids' thing, and I was the only one without that there. So it's just more weight, more isolation, and there was nowhere to go to talk about it, or I didn't know at that time. And even today, I'm well into the advocacy space. I do a lot of different spaces, but I've never really been in a talk where fertility came up and there was a focus on the men's side of it. And I don't have any ill fate or ill will towards that because I know it is so different from a women's perspective to a man's perspective, but it's just something that I really think needs to be addressed too, because there is a whole nother side to it. And it's just more isolating when you don't even have a pathway to that right now.
What do you see in women's advocacy circles that they're doing well that men's advocacy circles should adopt?
Well, I think that's a lot to do with us as men too, because we don't like to talk about things that make us feel vulnerable or make us feel embarrassed. Society has put a thing in, over many decades and years and stuff of a man, you're supposed to be able to provide. You're supposed to be able to have a kid. That if it isn't, is a weakness on you. Right or wrong, I mean, I don't think that's the right thing, but that's just the societal place that we live in. And even though it's changed over the last few years to where that isn't everywhere, men don't have that, but it's still very prevalent in the area that I live in or circles that I'm in. And I think so us as men have to be willing to be vulnerable and open up and address it for anything to change.
Yeah. And Cathy, in your practice, when you're discussing fertility with men, what are those conversations like? What are emotional barriers that you see from the provider standpoint? Is JJ's sentiment that we're not talking about it well, we don't open up well, is that lived out in the clinic experience?
I would say that, and maybe because we get a lot of people coming in for second opinions since I'm at an academic institution. So I feel that they're a little bit more open to talking about whether or not they're interested in sperm banking or family planning. I think the one thing that's still hard to get more insight from a male patient is just how they're doing overall in regards to their psychosocial aspect. So I am able to get information regarding their interest in family planning early on. But then just to see how they're dealing with their treatment and how they're handling their day-to-day lives, the stress associated with the treatment, the financial concerns, the job security concerns, that does take a bit of time and connection with the patient. And I can't see every single patient, every single visit that they come in. But every time I do see them, I do my best to try to connect with them and ask them about those aspects and ask their family member or friend that's accompanying with them if I'm missing something that they're not sharing with me. But it takes often multiple visits. It could be 6 months down the line before the patient opens up to me about some concerns about psychosocial stressors that they're impacted by. And then, but hopefully they open up because then we can provide them additional information since there's multiple resources that are available to patients, but we don't know unless you tell us, right? And so I just try to encourage providers to please continue to ask because it's usually not the first visit that you learn how you could help them. It's usually not the second or the third visit. It's multiple visits several months down the line.
Well, particularly with a topic as delicate and potentially consequential as fertility, a lot of times there's a time pressure to do sperm banking. You want to get it done before you start the therapies. But that's also when you were just hit with a cancer diagnosis. You have to face the potential mortality, associated with that. You have all these other decisions you need to make. And this is another thing that's not necessarily short term. Like this is something that could matter later. And it's hard, I imagine, to dig into that. And, Cathy, do you think there's a best time to talk about sperm banking, or is it's dictated by the cancer treatment? I
mean, the first time is always the best time, right? Before you get any treatment initiated. But it is dictated by the type of cancer you're going to provide. It's dictated by the symptoms that the patient may be having as well, right? So if they're symptomatic from their therapy, the urgency of the treatment may be warranted, especially if radiation is needed, etc. I think it also makes it very challenging, I'll be honest, for an academic institution is that we don't commonly have the facilities for sperm banking at the institution. So then it's another visit to another provider. Off-site commonly, right? So that also I think makes it a bit more tedious for the patient as well. And so it's important to keep those things in mind. But whatever, any time is better than not discussing at all. Let's be honest, right? And so there's keep the conversation going and make sure that if that family planning is still of interest to the patient, you still talk about it. Because even though maybe the treatment's been initiated or the treatment duration, you know when it's going to end. I mean, there's still an opportunity to still bank sperm later on. It's just that you obviously want to catch it before any treatment, because that's really where you're going to have the best chance of capturing as much sperm as possible for optimal outcomes.
Yeah. And JJ, I'm curious, if you were to think back before your treatment was initiated in your mid-20s, do you think you would have proceeded with sperm banking had you had this conversation?
Yeah, I would have definitely thought about it long and hard and stuff. And honestly, I don't know if I would have at the very first time, because again, in my head, it was, I'm 6 months and I'm going to beat this. I'm going to get back to living my life as a 28-year-old at that point. Now, when the cancer came back, I know it would have been the optimal time because I'd already had 12 rounds of Folfox and everything. But when the cancer had come back, I definitely would have, wouldn't even have to think about it. I'd have been full on board to like, let's do this before I start this next journey or step. But at the very beginning, because I was still in that mindset of, I'm going to overcome this. I'm 27, I'm strong or young guy. This isn't going to define the rest of my life. So I think I still had that mindset at the very beginning, good, bad, wrong, or not. But that was like my mindset at the very, very start of this. I was like, this is going to be a little blip on the radar of my life and not the rest of it.
Well, I think your response is incredibly honest, and I've seen play out where I think there's a lot of folks who, they're just like, I don't want to deal with that right now. We'll get through it and it'll be fine. And part of me, I don't know if that's psychologically triaging like you need to. You have certain things that you just can't right now. Like you have a lot on your shoulders. Or is it, is it appropriate psychologic triage, or is it denial? And I don't know how to differentiate those. What do you think back in the day?
For me, it was probably more denial. Yeah. It was more like, I'm not going to accept this. But I also wanted to point out, I think more people at the very beginning would be open and probably say yes to that if they were married or in a serious relationship. I was still single at that point. So as I said, the first few appointments, I was going there with my mom and I was just like, nope, we're good. We're going to beat this. Then I can go and have that whole part of my life. So I think, as we said, every cancer patient is very different from their cancer to how their life is going. And mine was just in that point right now. I hadn't been in a relationship in forever because I was, all focused on myself, as some early 20s, is graduate college, want a job, do all that. And so that was more of my life. And then it was just, I was in denial that anything was going to stop me from living the life I, worked and dreamed toward for 28 years.
I think that, what JJ just mentioned is really important as well. At least in my experience, if they're single and not in a relationship, I fully agree that is not high on their priority list by any means, even when you bring it up. It's definitely not high on their priority list versus if they have a spouse or a significant other in the room, then they really do think about it before starting treatment.
Why do you think that males who are younger, single, may be less engaged in fertility planning?
I think it's very similar to what JJ mentioned. You really just think that they're just going to overcome it. It's going to be just a small little hump in the road. They'll get over it, and their life will be back to where they where it was before their diagnosis. And I think that still holds true for a lot of individuals. And in part, it's hard to say, right? Is it denial? Just like you said, is it denial, or just the fact that they just feel that they are invincible because they're so young and appear so healthy, right? They don't look sick. The majority of patients nowadays do not look sick. They look quite healthy.
I have referred people to fertility planning before. Cathy, maybe you can speak a little bit to what the process is, what patients would anticipate with a referral to fertility planning.
The first thing is, number one, finding the right provider for the individual. And so we work with a group here in Nashville locally for our patient population. And then we just refer them as a standard consultation so then they can meet with that provider. I actually don't know what occurs when they meet with the sperm banking clinic, but I actually haven't. I don't know if I've really gone into depth and asked, but I do know. I mean, at least in the times that they've provided feedback back. I think that they just felt comfortable depending upon who the provider was at that end. And I think that's the most important thing, is that comfort level too. But I don't have a lot of other feedback to give you.
Well, I think your experience is exactly my experience too, is, speaking to maybe the uncomfortability around the topic, how it still is socially taboo to some degree, that of all the things that we refer our patients to, I'm not asking them, how did your fertility, how did your sperm sample going? Or, how did that go? But I've never heard a negative reaction that I can say. No one's ever brought up a problem.
Right.
And maybe that is good enough for a sensitive topic. I imagine it's going in there and, providing a sperm sample, whatever people think it is, it's probably that. But I haven't heard anything to the contrary.
Yeah, I would agree. I think my number one question was just to make sure that they felt comfortable in that office. And that was the most important thing to me.
Yeah. And, I remember when I first underwent medical training, and, I went through med school. I was in my early mid 20s. And you do open up to a world of vulnerability in other people that is new, to you. Before you were in medical training, you're not doing pelvic exams on your friends. You're not doing breast exams, you're palpating another man's, testicles, looking for testicular tumors. And I think going from that all being foreign to that all being routine, it really is routine. It really is like any other day. When you're on the medical provider side, there's no novelty to it after you work in the field. So the people who are working at the sperm bank, who are, facilitating getting these samples, this is their day to day. They do this, dozens of times per day. Any taboo that we would feel on the other side, not working there, they don't feel. This is just a mundane day. JJ, have you heard any stories, negative or positive, about the process of sperm banking, preserving fertility in men?
Not everybody I've talked to or had conversations that actually have went through there, they kind of say what y'all were saying. It was made to feel comfortable. And also, I think, like you were talking about, how it's routine for, medical professionals after you get into there. I know it took me a few years. It's very routine for me to get all kinds of exams and everything that other people would think is awkward. And I'm just like, you don't even bat an eye at it anymore. So I think again, depending on the patient and the time that they did this is there. But again, I've never heard anything negative about it from anybody that's ever talked to it. They said it was comfortable, as comfortable as they can make that in the situation of that part of their life.
Another element that is distressing around all this that we've touched on is the financial burden. Cathy, you'd mentioned this isn't always covered by insurance. Can you speak more to that process or how people navigate it?
So my understanding is that it's still considered it's under fertility planning. So in some states it is not covered. I became more familiar with it, obviously, because of my female patients and the concerns that arise in regards to financial coverage. But it's the same issue with the same states, and it's only covered. Number one, it depends upon your insurance. Number two, it appears to vary per state. And that's an issue. And it may not be a lot, but you also have to think about, you have to pay for storage, right? So you have to not only pay for the consultation, but you have to pay for the storage. It's usually, I think, a fee per month. And so not everybody has the financial capabilities to pay that extra fee. And there are various companies or resources that are available to patients for financial support. And I think it's really important to reach out to your social worker or case manager at your institution to get some information to see if there's coverage for you that's available that you can apply for. I think that is probably the most important thing. I know there's a lot of effort across the country to increase the number of states that provide fertility planning coverage. And I think there's been about 3 to 5 new states over the past year. So hopefully there'll be more momentum, but it's still not fully covered by all states.
Yeah. JJ, have you heard anything in the patient communities about the challenges of financial burden associated with fertility planning?
Yeah, I mean, a lot of it is dependent on their insurance or the state that they live in, but it's just another thing added on top to what we all deal with. And depending on insurance, I mean, I have Medicaid, Medicare, and stuff because I was working for my family when the time I was sick, and I didn't have insurance because as a single 27-year-old, I wanted all the money to come to myself because how could I ever get sick? You know, but it's just another added burden. And I hate that is the case because some of people I know, they've had to decide, but are we going to use the insurance or the extra money we have to pay to go to our doctors, to pay all the outside costs, not even just the treatment costs, the doctor's appointments, the parking, the travel here and there, and they can't afford that. And it's just another thing that people have to budget or decide. And I couldn't imagine being in that place to where you going to decide if you want to, the fertility or pay for the next round of treatment.
Yeah, especially if it's something with an ongoing charge. You have to balance in your head how worth it is this, especially if you're in the mindset of we're just going to get through this and we'll see then. Or if you're in another mindset that I think a lot of people find themselves in, which is what's the point? And that's tough because a lot of people, when they're first diagnosed, they're not in high spirits. This is a hard thing to get hit with. So fertility planning requires some optimism there. You have to be able to think that this might be a possibility in the future. And I could see how the perception of the world when you're looking at it through that lens really muddies the waters. It's interesting. JJ, have you heard of other barriers that are not financial or emotional that, prevent people from getting fertility preservation?
I'm in a lot of different communities and stuff, and I know some people, they won't do that for religious reasons. And, it's just different. And I'm not a, professional on different religious reasons or different reasons there. And I hear that and I'm like, totally respect you and everything. But I know that has to be hard. But then it's mainly, the financial or like you were saying, just the mental part of it, because it is hard to think of something positive, especially right when you're diagnosed and to make that decision. And then some people just, I don't want to say they don't want to have hope, but it's just such a hurdle to get over to think about what's next when you're faced with such a daunting task as a cancer diagnosis and to know everything you're going to have to go through to get through it.
Yeah. And, we're talking about all the barriers that occur once someone is referred. Cathy, what do you think are the current barriers that we can overcome in oncology clinics? Like, what can we be doing better to at least get the rate of referrals up?
For me, for every lecture I give, I talk about the rise in early onset colorectal cancer. I think that's the number one thing is really just to bring awareness to early onset patients. And number two, really also mention the importance of really just opening up this discussion and communicating that this has to be mentioned early on in the sequence of treatment, right? It should automatically be considered, I think, in the sequence of treatment when we're talking about therapies. And I think just really continuing to have individuals like JJ and others really advocate for themselves, hear their voices and their own experience. I think that's what really, really hits home for many individuals, and that's how they will remember.
One thing I've seen in this topic and other topics is that I think an important conversation for everyone kicks off because of individuals who are younger getting it and advocating more strongly, and probably it's because their comfort with social media, which I didn't use before starting this podcast. So I am learning it myself. But I'm wondering if you think that is there an age cutoff for evaluating male fertility or talking about sperm banking?
I think not so much for males, honestly. For females, yes, that is a matter of discussion. Obviously, the cutoff is late 30s, 40, but that's a different topic. But I think for males, I would not say that there's really an age cutoff at all.
Yeah, it's an interesting paradigm. I work mostly in lung cancers, and most people are diagnosed in their later years with lung cancer, and fertility for men, they're not usually, they've already had their families and they're not, if they're going to have families. And women are often past the age where it's a reproductive possibility. So we're like not that, I mean, I don't think we're as good as we need to be in the lung cancer field of asking it, making sure this is part of the checklist. But, there's certainly no harm. And, well, at least there's no harm in having the conversation. But it's funny, even my assumptions were creeping in. JJ, when you're talking about costs, I'm challenging in my head, like, why doesn't everyone just do it? If you don't need it, you don't need it. But then, oh, wait a minute, it's not free. Like, it's almost in my mind a no-brainer to do it if you're comfortable, because you don't have to use it, except it's not always covered. It's a bit of a travesty there. And so, yeah, I don't know how we change that, getting coverage other than, talking to your local legislatures and advocating it. But these social movements really do change things. I know we're having a kind of a renaissance in lung cancer screening, where younger folks are being diagnosed with lung cancer. Same thing's true in colorectal cancers. And we're getting these new modalities on how to screen in different ways than we used to. But I feel like we're behind with fertility preservation, particularly in men. JJ or Cathy, any other things that you think the community should be doing to increase awareness, to, push groups to get this covered?
For me, I just think open up, having the conversation, talk about it. And as advocates, definitely using the advocacy organizations, because in my experience, that's where newer patients come in and they trust them the most, because they're so personable and you can see people that look like you that's had these stories. And when you get that trust there and the information, then you can take it to the medical professionals. And I think that kind of, pathway and like organization of it is the best way, because when you're diagnosed, the first thing you're going to, no matter who says not to, is go online, go to social media, go type in something. I mean, I've heard a million times where people are like, don't look it up, don't do this. We're in that age right now. We're going to do that. I still do it. So I think just using the things that we have available to us in advocacy organizations and, advocates like me and so many others I know, to hopefully keep opening up and talking about this, to gain the trust of the, unfortunately, newer patients that will get diagnosed, so they can be better prepared than I was 10 years ago.
Cathy, is there any particular thing that you would end on telling your male patients in hopes that they'll better understand or better be prepared for fertility preservation?
I would just say, just be open to the discussion and don't be fearful of being vulnerable. I mean, we're here to help, and we obviously want to, help the patient fight their cancer, but also we want to make sure we think about the future of the patient, right? And where their life may lead down the road. And so we have to be cognizant of that.
And JJ, if you could tell someone who was in your shoes when you were first diagnosed, how would you advise them around fertility preservation?
I would say go in, ask about, don't be embarrassed, be open with what you want. Don't think you're Superman or invincible, because you never know what's going to happen, as scary as that sounds. and just be open to the possibility. So you can have a conversation and you don't have to make a decision, make what's right for you, but just make sure you have that conversation.
Well, I think that's a great place to cut it today. Thank you both so much for joining us. And I think this was a great talk. Hopefully, folks listening, this has achieved the goal of maybe minimizing a little bit of the stigma around male fertility preservation. And if it's something that you've had a positive experience with, talk about it. Let people know that it's something that they have access to, and don't be afraid to bring it up to your providers, because we are not perfect. We forget things, we drop the ball too, and it takes a village, and you're the one that has to deal with the consequences of anything that happens. So this is something that that we need to work together as a team on. Well, thank you, Cathy and JJ, for joining. We'll cut loose now. See you next time, everybody.
Thank you so much.
Thank you for joining us on this episode of Cracking Cancer. If you found this helpful, please like, subscribe, leave us a review, and visit crackingcancer.org for more information. Every dollar we earn goes directly to furthering the podcast and supporting vital cancer research. Because together, we can crack cancer.